So the skip pain trial is a special trial which was designed in order to address patient unmet needs. And it has several particular features. So the study had a focus on spinal pain as a cardinal symptoms of axial spondyloarthritis. It had elements of strategy trial with escalation of the drug dose in patients not responding well. And finally, that was the first study that addressed the entire axial spondyloarthritis population treated with IL-17 inhibitor. The main take-home messages out of this study are: first, secukinumab is effective in reducing spinal pain in patients with axial spondyloarthritis in the entire spectrum, including both non-radiographic and radiographic. The statistically significant reduction was observed already early in the course, and the primary endpoint was measured at week 8, and secukinumab was significantly more effective than placebo at this time point. And finally, in patients who are non-responders, there was an additional benefit from dose escalation from 150 to 300 milligram. However, also patients who continued after week 8 on 150 milligram of secukinumab, they also showed some improvement over the following weeks. Therefore, week 8 might be not the optimal time point to measure the full response to secukinumab. So for me, in a clinical practice, this would mean that I would wait probably at least 12 weeks before I make a decision whether the drug dose is enough or not. As you know, secukinumab is approved for axial spondyloarthritis in 2 dosages, 150 and 300 milligram, giving every 4 weeks. There is, however, no clear evidence that up-titration of the secukinumab dose might be beneficial for those patients not responding to 150 milligram. And skip pain was the first study which addressed this data gap, and patients who showed no response, so no sufficient improvement of back pain after 8 weeks of treatment, was randomized to continuation of secukinumab in 150 dose or to 300 milligrams, so up titration from 150 to 300 milligrams. And what we observed, we saw a more prominent reduction of pain, but also of disease activity in patients who were up titrated to 300 milligram. So overall, we still have some data gaps related to the role of IL-17 inhibitors in the axial spondyloarthritis. We still do not know whether patients responding to IL-17 inhibitors are the same patients responding to TNF-alpha inhibitors. So we need certainly strategy trials that would help us to define the appropriate patient for appropriate drug. Second part of the story of IL-17 inhibitors is inhibition of structural damage progression. There was a signal from pivotal studies with secukinumab that secukinumab or IL-17 blockade might be associated with a reduction of radiographic spinal progression that might be related not only to inflammation but also to direct inhibition of new bone formation. And this is something that is being currently addressed in a head-to-head trial, secukinumab versus adalimumab biosimilar. And the results of this study are awaited next year, and we will certainly learn a lot about optimal treatment of patients with axial SPA with both drug classes in terms of structural damage progression, but also in terms of clinical response to this therapy.